Good morning, everyone. My name is Ravand Samaeekia. I'm a second-year internal medicine resident at Loma Linda University Medical Center. I'll be speaking about fevers of unknown origin when opossums bring on the heat. Murine typhus is a febrile disease caused by Rickettsia typhi, which is often described as a master of disguise, as it can present with non-specific symptoms. Humans become infected with Rickettsia typhi through accidental contact with infected fleas and their feces by inhalation or scarification into damaged skin. It has been noted that in the recent flea-borne rickettsiosis outbreaks, the classical murine typhus urban transmission cycle involving rats has shifted to a suburban cycle that involves cats and opossums. While the number of cases reported in the United States has decreased, murine typhus has remained an endemic disease and a public health concern in Southern California. So here we present a case of a 57-year-old female presented with cough, shortness of breath, and fever for 2 weeks. She had an extensive history of animal exposures to horses, goats, llamas, and alpacas during a recent trip to Arizona. She and her daughter also bathed flea-infested, urine-soaked opossums and sustained scratches on her hands during the process. Her daughter also presented with similar symptoms and was admitted to the pediatric floor. So you can see in the workup section that she presented with vitals, that showed sepsis. Temperature was 103.5. She was tachycardic and almost tachypnic. White count was elevated. LFTs were elevated. So we ordered blood cultures and serologies were also sent for Rickettsia, for Rickettsia spotted fever group and murine typhus group, and a few other bacteria that were highly suspicious for this, including Francisella tularensis, Coxiella, Leptospira, Bartonella, Legionella, and some of the highly suspicious fungal agents as well, including Aspergillus, Crypto, and Coxy. We also sent a respiratory virus panel, including COVID, which was negative. CT test and a TTE was also ordered. So TTE came back normal. CT test, as you can see in the figure 2, showed bilateral flame-shaped nodular consolidations with mediastinal and hilar lymphadenopathy. The patient, despite all the recommendations, declined diagnostic bronchoscopy. Blood cultures and serologies were negative except for Rickettsia organisms, with the spotted fever group IgM titrating 1 to 512, but IgG less than 1 to 62, and murine typhus IgM 1 to 1024 and IgG 1 to 512. Both of these were acute specimens. So the patient was initially empirically treated with IV doxy, ceftriaxone, and gentamicin, which helped her fevers and respiratory status improved, and she was subsequently discharged on a 2-week course of oral doxy and augmentin. So in terms of discussion, this is a great case showing that a timely diagnosis and treatment of febrile illness, especially when suspicious for an uncommon yet endemic pathogen is high, is of utmost importance in the timely disease management. In this case of murine typhus in Southern California illustrates several key issues when considering this pathogen as a cause of fever. Some of them include the fact that the most common signs of symptoms are nonspecific, including fever, headaches, chills, and rash, and often history of flea exposure and bites is typically not recalled by the patient. So a definitive diagnosis is usually retrospective, requiring at least a 4-fold rise in convalescent antibody titers. And finally, empiric treatment should not be withheld while awaiting diagnostic studies. So in conclusion, the diagnosis of murine typhus can be elusive, especially in the context of sepsis with an unclear source. A thorough history of animal exposure is paramount when there is suspicion for flea-borne disease in an endemic area. Here are my references. Thank you for listening.